Very much for this kind invitation in this session. I have no conflict of interest to declare for this particular lecture, as usual. First of all, non-invasive ventilation and outcome. These are the recent guidelines published on non-invasive ventilation in acute respiratory failure. And this is just to show you that for de novo respiratory failure, that this is the topic that we are discussing today, there are no recommendations made, and there is not much certainty of evidence. Then I go back to this study that will be commented later, which is an observational trial, so it's not a randomized trial. This is very important, in which they showed that non-invasive ventilation is used in 15% of patients with RDS. And in those patients with a PO2 FR2 higher than 150, they did not find any difference in terms of survival between invasive mechanical ventilation and non-invasive mechanical ventilation, while in those patients with a PO2 FR2 ratio less than 150, they found an increase in mortality in those patients treated with non-invasive ventilation. From here to conclude that non-invasive ventilation is associated with increased mortality in terms of treatment, I think we cannot conclude that because this is not a randomized controlled trial. But however, there is this association. And you see here that the tidal volume was higher in the non-invasive ventilation group as compared to controlled mechanical ventilation. The PEEP was lower in the non-invasive ventilation as compared to controlled mechanical ventilation. Respiratory rate was much higher in non-invasive ventilation compared to control, and the FiO2 was more or less the same. So from this data, it seems that non-invasive ventilation, the setting of non-invasive ventilation, does not really follow the recommendation for the treatment of RDS patients, especially for more severe patients. So now first we discuss the role of assisted ventilation in acute lung injury. The question is that if we develop a negative pressure in the pleura, we would expect a higher transpulmonary pressure as compared to controlled mechanical ventilation from the same inspiratory airway pressure. So if you have inspiratory airway pressure of 30 and you have inspiratory effort, for example, minus 15 centimeters of water, which is too high, but it's just to have an easy way for computation, you have a transpulmonary pressure which is equivalent to 45 centimeters of water. If you apply 30 centimeters of water in the airways, in the respiratory system, and you have a controlled mechanical ventilation without inspiratory effort, for example, you have an increase of 15 centimeters of water in the pleura, you have a transpulmonary pressure of only 15 centimeters of water. So wherever you have an inspiratory effort, for the same airway pressure, you increase the transpulmonary pressure. So you can have different conditions in assisted ventilation. The first condition in which you have low PEEP, like non-invasive ventilation from Lung Safe study, and you increase the pressure in the inspiration. So the effect is that you keep the collapsed area and you just overventilate the aerated area. On the other side, if you apply not enough PEEP, you have a condition in which you have a continuously opening and closing of the dependent lung or the collapsed lung. On the other side, if you use very high PEEP level, even associated with moderate inspiratory support, you can have some overdistension. So the best condition, even during assisted ventilation, is to maintain probably an homogeneous ventilation in the lung aeration. So which are the animal data? This is a study from the Amato group in which they compared, in this case, mild lung injury without spontaneous breathing. You see here the esophageal pressure positive, flow, and pressure. Then here you have mild lung injury with spontaneous breathing. You see here the negative pressure, exactly what happens during non-invasive ventilation or assisted ventilation. And you have a reduction in the lung injury. Then you have a condition in which you have severe lung injury, the PO2 FO2 ratio less than 150, and you have in controlled mechanical ventilation, and of course you have more damage here because you have more severe injury as compared to mild injury. But when you associate assisted ventilation or spontaneous ventilation to severe lung injury, look what happens. This is the inspiratory effort again, so the negative pressure that I showed you before, major damage in the lung. So this experimental study shows clearly that if you apply spontaneous breathing in a condition of severe lung injury, this may promote further lung injury. While if you have assisted spontaneous breathing with mild lung injury, this is associated even with better condition in the lung. But we have also our data, many studies with Marcelo de Abreu Gamma Group in Dresden. This is one of the most recent one in which we compared in moderate lung injury a type of assisted ventilation with not so high effort. And what we found is that transpulmonary pressure during assisted ventilation, this is the BiPAP IRP at 0, 30% spontaneous breathing, 30, 60, or 60%, was lower during assisted ventilation as compared to controlled, because we adequately sedated the animals, and we will be back on that soon. And we found a major reduction in the lung damage in the dorsal or overall lung when we applied assisted ventilation with adequate sedation and not too much spontaneous effort. So now we have very recent data in which we applied regional pressure in the lung. And I don't want to be too long here. This is the KI, so the lung injury measured by PET in vivo. And these are controlled mechanical ventilation with higher PEEP or lower PEEP, and this spontaneous ventilation with higher PEEP and lower PEEP. And you see that the main difference was due to the PEEP, not to the controlled assisted, once that you sedate adequately the animal. Because we are a more homogeneous lung. And interestingly, this I think is the most important slide here to conclude the first part of my talk, is that you see that the dorsal transpulmonary pressure, this is the transpulmonary pressure measured by wafers on the dorsal part of the lung, the real transpulmonary pressure during spontaneous breathing during lung injury, higher is this effort, higher is the KS. If it is lower, you have much lower. So this clearly demonstrated the regional transpulmonary pressure that you achieve during spontaneous breathing, even also during non-invasive ventilation, is the main determinant for lung injury. So we go back to the humans data. This is the first study showing that higher tidal volume was associated with non-invasive ventilation failure as compared to non-invasive ventilation success. And you can see a major difference. Also a major difference in minute ventilation. We are back to the slides that I showed you before in animals. And you see here that the predicted tidal volume was 9 milliliters per kilogram predicted body weight in those patients who failed non-invasive ventilation and lower in patients who did not fail. And the pressure support was more or less the same, and the PEEP was the same. So this means, from the slide that I showed you before, that these patients were likely to have a higher effort as compared to these patients. They were likely to have higher transpulmonary pressure, likely in the most dependent part of the lung, and so they likely had more lung injury, and they also developed more respiratory failure. On the other side, it's possible that they were more sick patients, so they had higher respiratory drive compared to the other. And this is a sub-analysis, a secondary analysis from the study from FRAT in non-invasive ventilation. And you see that those patients with a higher tidal volume had a higher probability to die as compared to patients with lower tidal volume during non-invasive ventilation. Finally, this study was recently published on CCM. And what they found, again, non-invasive ventilation success or failure, in patients with mild hypoxemia, not big difference in tidal volume. I show you, in mild hypoxemia, this does not make major difference. But in those patients with moderate to severe hypoxemia, you see that the tidal volume was much higher in those patients who failed. Again, we don't know, it's because the patients were more sick or not, or because the higher tidal volume during non-invasive ventilation induced more lung injury and promoted the failure of non-invasive ventilation. And as you can see here, the percentage of NIV failure was higher in those patients who had at 4 hours, so very early, a higher tidal volume. This is another important concept. Very early is not just after 24 hours or 48 hours. So you have to be very careful of this parameter since the beginning. So higher mean tidal volume was associated with NIV failure, with a 29% increase in risk failure for each milliliter per kilogram predicted body weight increase in mean tidal volume. But can we ventilate with tidal volume, lower tidal volume? Okay, now I show you higher tidal volume, especially in higher severity, is not good for our patients. But can we do something to do that? We have some difficulties. Look at again at the data from Carter. Here you see that only in 20% of the patients it was possible, even if you reduce the pressure support, to reduce the tidal volume within this limit. Because the inspiratory effort is so high in these patients that it is not possible, unless you sedate, I will show one slide on that, to reduce the tidal volume. And these are also our data showing that even if you reduce the pressure support, you see that the percentage of the tidal volume is always in the rib cage and not in the abdomen. This is not natural. Usually we have more in the abdomen than in the thorax in supine position. And the phase shift was much higher with low pressure support. So wherever we reduce the pressure support, we have a desynchrony in the chest wall and the abdomen because the respiratory drive remained too high. So asynchronous during non-invasive ventilation. This is a very nice study by Carlucci showing that 60% of the patients during non-invasive ventilation, they have asynchrony. And most of them are due to ineffective effort or double triggering or auto-triggering. And I remind you that if you have asynchronous, like here on the right, you see here how much transpulmonary pressure, you see the esophageal pressure here, how much is the swing? Almost more than 20 centimeters of water, and you have to add the pressure here of pressure support, other 20 centimeters of water, almost 40 centimeters of water of transpulmonary pressure during asynchronous. This is damaging the lung. So sedation. The other possibility, I show you that it's not possible to reduce pressure support. We can sedate the patient. Now there is a big debate. This is a very recent debate on is sedation helpful? Is sedation not helpful? This is from one of these you see here. This is interesting. You have the electrodiaphragmatic activity of the diaphragm, and you see that then it's decreased, but the flow is more or less the same with a reduction in respiratory rate. This is why the patient was a little bit sedated with propofol. So with some sedation, I don't discuss here propofol, dexmedetomidine, for example. Now we had a very good experience on that. But just to say to you that the targeting appropriate sedation may be probably more helpful to reduce the pressure support in this kind of patients if we want to try to have less inspiratory effort. And this is again a study very recently published showing that, however, different data showing that analgesia and sedation was associated with an increase in the failure and PPV. So probably, however, when we need the sedation in order to reduce tidal volume, we are going towards the failure on non-invasive ventilation. Then we don't know if it is sedation per se or is a consequence for failure on non-invasive ventilation. But this is something that we have to take in account. So I want to finish with just a few practical advice with these graphs that I think can be important to understand the concept we discussed. This is what happened in a passive patient. In blue is the pressure. It can be pressure support, pressure control, BiPAP, whatever you want. And in yellow, brown is the pressure in the pleura. Okay? In controlled mechanical ventilation, you have an increase in both. So the transpulmonary pressure is the difference between the increasing esophageal pressure or pleural pressure and the level of inspiratory pressure. Now, we have a patient with relatively low effort in non-invasive ventilation, and the same, I think, applies for assisted ventilation. You have some effort here, and then you become passive here. And you see here, you have a little bit increase in transpulmonary pressure. Wherever you have some inspiratory effort, in pressure control or pressure support or pressure limited, the transpulmonary pressure during inspiration is always higher than during controlled mechanical ventilation. And if the effort is much higher, this transpulmonary pressure is much higher. And which is the main message from this slide to me? Is that you have the same inspiratory pressure in the airways. So you say, okay, I'm ventilating the same way, but this is not true. You don't see the hidden part of the iceberg, which is determinant for lung injury. Second slide. This is when we increase tidal volume. What does it mean? So this is a patient, again, in assisted ventilation or non-invasive ventilation with minimal effort. And we discussed that just before. Now, we increase the pressure support, okay? So we have some relaxation of the respiratory muscles, but if we increase the pressure support, we likely increase the tidal volume, and we likely increase the transpulmonary pressure. We decrease the pressure support, and we believe that we are decreasing the driving pressure. No, the real driving pressure in the transpulmonary pressure can be higher exactly as much as when we increase the pressure support, or even higher. Because at least in this case, we suppose that we have some relaxation of the chest wall at the end of respiration. That is not the case in this case. So the conclusion is that the driving pressure during controlled mechanical ventilation is always lower than the real transpulmonary driving pressure during whatever system of assisted ventilation. So we don't see the hidden part of the iceberg. And this is what happens during assisted ventilation. So the conclusion are that non-invasive ventilation has been found associated with worse outcome, especially in moderate to severe RDS. Experimental studies shows that spontaneous breathing may be associated with increased VILI, but now we know why. Only when there is an increase in the regional transpulmonary pressure. And likely when lower PEEP is used. Clinical studies suggest that higher tidal volume during non-invasive ventilation is associated with failure and worse outcome. Lower tidal volume, however, during non-invasive ventilation may be achieved in only 20% of the patients, even if you try to reduce the inspiratory support. Patient ventilator asynchronous are very frequent, and I show you how much dramatic they can have to reach up to 40 centimeters of water of transpulmonary pressure, which is impressive. Sedation, however, may play a role to optimize non-invasive ventilation. However, I show you also that if you need too much sedation, it's very likely that the patient is going to fail. Respiratory driving pressure is always lower than the transpulmonary driving pressure, especially at higher respiratory rate. This is, I think, a dogma. And excessively high respiratory rate, higher than 25, or minute ventilation higher than 15, should be avoided, in my opinion. And finally, I show you that perhaps now we concentrated on the regulation of pressure support, sedation, but I show you that now we have data, also experimental, suggesting that probably we have to learn more about the titration of PEEP during assisted and non-invasive ventilation. That we have very few studies, except that I showed you before, and some study from Amato Group discussing the issue of PEEP titration during inspiratory effort. Thank you very much.
Thank you, Paolo. Any question from the audience? Please introduce yourself.
Thanks you for your presentation. I am Dr. Núñez from Santiago de Chile. The question is if spontaneous ventilation is good or it's bad, okay? And I think if you use a better triggering system like NAVA systems in NIV, you won't have that kind of problems you showed there. So the problem is when you have controlled ventilation, the asynchrony and the double triggering and the sedation is much more heavy because of that. And we all know that sedation kills more the patients. So, and the asynchrony, it takes you to worse outcomes. So when you put it, which is worse, the spontaneous or control?
So regarding NAVA, of course, I had no time now to discuss all the methods. I did not show too much about NAVA because I think that we have not real definitive data on this technique. It's not easy to be applied, especially in patients in non-invasive ventilation. I think that before we have, it's expensive, and before we have real clinical data suggesting some beneficial effects, personally, we are very cautious to apply this technique. Also because using NAVA, this does not mean that you have a control of the transpulmonary pressure. Sometimes you have even a sort of recycling, and even you have higher inspiratory effort when you use the techniques, or you have higher transpulmonary pressure than really you need. Regarding assisted or not assisted, I think that the data actually suggest that if we should be very careful to apply whatever technique of assisted ventilation or non-invasive ventilation, especially if the respiratory drive of the patient is too high. And this is likely associated with more severe damage of the lung. Now we are much more restrictive in the use of non-invasive ventilation in our patients. Even if we are obliged to use, for example, in immunocompromised patients, we try not to intubate as much as we can, but we try to be extremely careful. So wherever we see that the patient is not improving, we try to intubate the patient as early as possible.
Thank you, Paolo.
Thank you very much. We are already late, and